is Molly Butler, and I'm excited to tell you about my DNP project. The title of my project is Telepsychiatry Safety, a strategy for improving provider confidence, managing suicidal patients virtually. So my committee, my chair was Dr. Snell, my second reader, Dr. Stegman, and my community person was Dr. Vick. An overview before we get started. We'll do a brief introduction to some important themes for my project, talk about my purpose, go through some really important literature review themes that I found, and then also talk about my project design, the methods, my instruments and procedures, and then finally my data analysis and discussion. So, beginning with the introduction, suicide assessment is an important part of my project. So, we know that the management of suicidal patients is a very critical skill for all psychiatric and mental health providers. Suicide is unfortunately a leading cause of death for ages 10 to 34-year-olds, and the fourth leading cause of death for ages 35 to 54-year-olds. Half of the people who complete suicide and 2/3 who have attempts have been given either a psychiatric diagnosis or received a psychiatric treatment in the preceding year. And at any point in time, about 15% of outpatient psychiatry patients endorse experiencing suicidal ideation within the past week. This project was done at an outpatient practice, so that statistic is really important for what I was looking at. We also know that COVID causes significant burden for people with mental illness. So we know that health crises are historically cause an increased risk for suicide, and that includes because COVID increased social isolation, job insecurity. We were really uncertain about the future. There was more stress, and we know that anxiety globally disproportionately affects people with mental illness. Another important piece of this project is telehealth. So just a brief definition. So telehealth, or a virtual visit, is another name that I'll use throughout this project, is a two-way synchronous audio and visual connection like Teams or Zoom. And it has been available for 50 years, but the pandemic really created a turning point for the use of telehealth in healthcare. In 2020, with the initial surge of the pandemic, the rate of telehealth increased over 550%. And in 2020 to 2021, over 80% of physicians saw 75% or more of their patients using a virtual platform. In a 2021 survey after the initial surge of COVID, over half of the providers were interested in continuing to use telehealth for more than half of their client visits, and 64% said that they wanted to use it for at least a quarter of their clients beyond the pandemic. Another important piece of this project is the knowledge gap. So we know that mental health providers were required to bring their unique skill set to the virtual platform because of COVID, and this included both the assessment and management of patients with suicidal ideation during telehealth visits. So while working with suicidal patients was never excluded from leading psychiatry telehealth recommendations, providers were really concerned about this specific unique clinical care skill. Only 21% of mental health clinicians ever had experience using telehealth with suicidal patients before the pandemic, and providers had a general wariness about doing this type of care. In terms of my specific expertise and interest for this project, I'm a psychiatric mental health nurse practitioner with over 15 years experience. I have a really high level of comfort with suicidal patients during face-to-face encounters. But now, at the time of the beginning of this project, our outpatient practice was utilizing telehealth for over half or more of our visits. The advantages of this were decreased COVID risk and increased access to care, and the concerns were that we had no additional education or support for managing patients in crises during telehealth, and there was uncertainty both in myself and during discussions with experienced colleagues about this kind of care. So, the purpose of my project was to increase provider confidence in treating patients at risk for suicide, via telehealth through a training and implementation of evidence-based telehealth safety guidelines. So now we'll go through several literature review themes that were really important in thinking about how to address this gap. So the first was the utility of telehealth in mental health care. We know that telehealth is really important. So the surge of telehealth with COVID created a really important turning point with these comprehensive benefits. So telehealth increases access to quality care, cost savings, and it's convenient and flexible for both clinicians and patients. Also, the evidence shows that there's no difference in virtual visits between in-person visits with therapeutic relationship, patient retention, assessment, treatment, and patient outcomes. So the literature really does support the use of telehealth. A second important theme was provider perceived telehealth risks. So over half of providers reported a lack of specific education and training to use telehealth for patients experiencing an emergency. Clinicians have a lot of patient-centered concerns, so they were worried that they'd have difficulty picking up on important but more subtle nonverbal cues of emotional distress during virtual visits. They were worried about distractions within the chosen telehealth environment. They were worried about a difficulty engaging patients, lack of available support, complicated logistics, and also the potential for losing connection with a patient. A third important theme was provider self-confidence. So nurses' confidence in providing care via telehealth was generally low, according to the literature. Providers said that they would feel more confident in providing telehealth services if they were given hands-on training. And self-confidence, we know, is positively correlated with motivation to act, determination, resilience when faced with adversity, and ambition in the pursuit of goals. We know that confidence is an important attribute for nurses to possess to deliver high-quality patient care. Next important theme was interventions to support suicide safety. So the literature supports that following suicide training, providers reported an increase in confidence in assessing suicidal patients, and they used evidence-based suicide assessment techniques more often. The implementation of guidelines with a simulation activity modeling the use of guidelines for suicidal patients is shown to be an effective education strategy. And finally, the final literature review theme is telehealth-specific suicide prevention interventions. So clinical training should educate providers on ways to identify suicide risks specifically during telehealth visits and how to support patients through transitions of care if they do require inpatient psychiatric admission. Also, specific suggestions from the literature is that there should be a clear pre-planned process in place. So, next, moving on to project design overview. So, to consistently implement new practice guidelines, support provider confidence, and promote patient safety, a quality improvement project was implemented through the following steps. So first, electronic telehealth safety guidelines were distributed to providers. Providers participated in a simulation guideline training session. Then the providers implemented these safety guidelines into their telehealth practice. And then the researcher determined the impact of the training and guideline implementation on provider confidence, utilizing surveys through a quantitative pre- and post-test design. And we'll look into this a little bit further. So the setting for this project was a psychiatry private practice in the Southeast United States. The participants were a convenient sample of colleagues of the researcher. This included 9 psychiatry providers, 2 psychiatrists, and 7 psychiatric mental health nurse practitioners that were employed in the practice. The participation in the study was not required for employment. The decision to voluntarily participate would not affect employee relationships or employment-related decisions, and participants were able to not include data or not participate further at any point in time during this intervention. In terms of recruitment, a group email from a practice administrator inviting interested clinicians to reach out to the researcher for further information was sent out, and you can see a copy of that here. Then the interested clinicians reached out to the researcher and they were given a little more information about the project and then screened with the following inclusion and exclusion criteria. So they had to be a licensed psychiatrist or psychiatric mental health nurse practitioner. They needed to be employed at the practice where the researcher worked in Nashville. They needed to be currently providing outpatient psychiatry services via telehealth to patients that were specifically at risk for suicidal ideation or suicidal behavior, and they needed to agree to participate in the study. Exclusion criteria was that if these clinicians were already using guidelines or protocols for treating patients with suicidal ideation via telehealth, they couldn't be included in the project, and if they had previously completed a training on treating suicidal patients via telehealth, they were also not able to participate. In terms of methods of evaluation, so those meeting inclusion criteria completed a pre-intervention adapted version of the Zero Suicide Workforce Survey, and we'll talk a little bit more about that here in a minute. Participants were given a training and evidence-based telehealth safety protocols to implement into their practice. They did this for 6 weeks, and then they repeated the same survey for comparison. In terms of instruments and procedures, so they accessed the surveys through Qualtrics, and it was an emailed link. These were anonymous, and it was a password-protected account. These were identical pre- and post-intervention surveys. They were 8 items. It took less than 10 minutes for the clinicians to complete. These were Likert scale questions, and they were a 5-point scale ranging from strongly disagree to strongly agree. We know that Likert scales have approximately 88% reliability. This was an adapted version of the 66-item Zero Suicide Workforce Survey. This survey was initially designed to assess staff comfort and knowledge in managing suicidal patients, and the authors recommended a response rate of over 65 to 70% to establish reliability. Here's a sample survey question so you have an idea about what that looked like. So this one is the example of, I'm confident in my ability to provide care to individuals who have been identified as being at an elevated risk for suicide during a virtual appointment. And as you can see here, there were 5 response options ranging from strongly disagree all the way to strongly agree. And here is so that you can see the actual telehealth safety protocols that the providers received. It gave really specific instructions for providers to use prior to the telehealth encounter, and then also when they were initiating the encounter, and then for the safety assessment during the encounter, and then finally interventions as indicated if the patient was requiring a higher level of care and how the provider could go about that. So that brings us to our data analysis. So since this was anonymous, I don't have information regarding the specific participants, but we can talk about the convenient sample as a whole. So this were psychiatry providers, like I said, in this private practice. 78% were women, 22% men. These were really educated providers. 55% of them have a doctorate degree, 45% have a master's degree, and they were also really experienced. Over half of the providers in this practice have 11 or more years experience. 33% have been practicing for 6 to 10 years, and only 11% have less than 5 years experience. The response rate was great. So on pre-intervention, we had an 88% response rate, and you can see that in this top pie graph with the orange is a response, blue is no response, and then the post-intervention was a 75% response rate. And you can see that in the lower pie graph here, the orange response, blue no response. And so did meet the goal of the authors of the Zero Suicide Workforce Survey that was previously mentioned for reliability. So this was a quantitative method project. A total score was calculated for each survey, and the scores were entered into a spreadsheet and then uploaded into SPSS. Then a Mann-Whitney test was run to analyze the two groups of non-normal data to determine if there was an improvement in competence. This found that the variability of the post-intervention survey scores was lower than the pre-intervention survey scores, which was good and indicated a more homogeneous data set with the post-intervention surveys. Next, we found that the post-intervention survey scores with a mean of 39.67 were higher than the pre-intervention survey scores. You can see that on this bar graph here. The blue indicates the frequency of the pre-intervention scores, and the orange indicates the post-intervention scores. This Mann-Whitney U-test had an effect size of 0.05, which indicated that the pre to post difference scores was statistically significant, and you can see that here in this table. That brings us to discussion. So the outcome of this project was consistent with existing literature. I was able to improve clinical competence in assessing and managing suicidal patients via telehealth through a training and evidence-based protocols. This supports the need for assessing and addressing ongoing knowledge and competence gaps, even in experienced providers. In terms of benefits to the practice, providers and patients, so for the practice, decreased provider error and liability, and it promoted the practice goal of offering telehealth to all patients and not having to leave out patients that were at risk for suicide. In terms of providers, they had improved competence, and it decreased the individual burden of navigating this shift from in-person to telehealth visits on their own. And finally, for the patients, they're now managed uniformly with evidence-based procedures aimed at protecting their safety. The strengths of this project. So these protocols were developed by a clinician with years of experience integrated into the system where the project was implemented. So I understood the culture and the clinicians and the patient population needs, which helped anticipate potential obstacles and target an area of true need. The sample population for this study was quite experienced, so the ability to quickly and effectively improve skill-based competence in a group of highly experienced clinicians emphasizes the true impact of this project. And finally, this project took very little of providers' time, and it was still really impactful. So this leads the way for more tailored education and guideline support in this practice and beyond. In terms of limitations, the sample population was small, and all participants were colleagues of the researcher. So this could likely lead to a bias of report for the clinicians to report positive results of this study, and also the small sample size limited the generalizability. The Zero Workforce Survey, which was used as the data collection tool for this project, had no published reliability and validity, limiting the strength of the data. And finally, the Zero Suicide Workforce Survey was adapted to fit the specific needs of this project, which could interfere with the strength of the data. Post-implementation insights. So facilitators, the owner of this practice where this project took place was immediately supportive and flexible with the implementation timeline and strategy. Maryville Universities were instrumental, Maryville University professors were instrumental in giving me guidance and feedback during each phase of this project, which helped it go smoothly and be meaningful. It was also invaluable to engage with peers through discussion boards and to receive suggestions and support throughout this project. And finally, my family and friends were incredibly supportive throughout this entire program. Barriers to the project. The first that for me, it was difficult to identify a gap at the clinical site that was problematic enough to get administrative and clinician buy-in and get them to be attracted to participate in this project, but that the problem and the gap wasn't urgent enough that it needed to be addressed by practice leadership quicker than the timeline of this DMP project would allow. And finally, it was difficult to find a reliable and valid measurement tool. This project aimed to measure a really unique phenomenon, and finding a specific tool for this was a bit challenging. And then ultimately a tool was adapted, but this potentially interfered with capturing the data appropriately. In terms of further research, so certainly could be helpful to measure the impact of protocol implementation and this increased provider confidence and how that impacts outcomes and satisfaction for patients. In terms of sustainability, the guidelines can be adjusted as needed to fit clinic needs, and the researcher will continue to stay informed about any telehealth safety recommendations that come out in the future. In terms of dissemination, I will share the results with clinic leadership and psychiatry clinicians, and the protocols can also be shared with therapists that are also working in this practice and use telehealth. Also, I'm a nurse educator, and so the project protocols will be shared with students while learning about incorporating telehealth into their psychiatry practice in the future. And that is the end. Thank you for your time. And here are my references.